Hello everyone, and welcome to today's cardiovascular imaging case review. In this session, we'll be examining a unique and instructive case of biopsy-proven wild-type transthyretin cardiac amyloidosis, or ATTR-UT, with an unusual imaging profile, specifically abnormal cardiac MRI findings but negative nuclear scintigraphy using both 99 mTc HDP and 99 mTc PYP. Let's begin with the clinical presentation. We have a 69-year-old male with a past medical history of type 2 diabetes, hyperlipidemia, and non-obstructive coronary artery disease. He presented to the emergency department after experiencing several months of cough, orthopnea, and lower extremity edema. On physical exam, the patient was afebrile with a blood pressure of 168/78, heart rate of 81 beats per minute, respiratory rate of 18, and oxygen saturation of 95% on room air. Auscultation revealed expiratory wheezing. He also had bilateral pitting edema, but there was no jugular venous distension. Initial laboratory testing revealed a high-sensitivity troponin T of 179 nanograms per liter, with the normal range being less than 23. A proBNP of 5,780 picograms per milliliter. Normal is under 125. The electrocardiogram showed normal sinus rhythm, left-axis deviation, and nonspecific T-wave abnormalities. Given the clinical picture, a transthoracic echocardiogram was performed. This transthoracic echocardiogram demonstrates severe concentric left ventricular hypertrophy, evident by uniform thickening of the interventricular septum and posterior wall. The ventricular cavity appears small, and the myocardial texture is suggestive of an infiltrative process. Despite the increased wall thickness, systolic contraction is vigorous, consistent with a preserved ejection fraction around 65%. These features are classic in early-stage cardiac amyloidosis. In this apical four-chamber view, we observe preserved left ventricular systolic function. However, note the abnormal relaxation pattern and reduced early diastolic filling, suggestive of diastolic dysfunction. This is typical of restrictive physiology, commonly seen in cardiac amyloidosis. The atria are also mildly enlarged, a compensatory response to increased filling pressures. This subcostal view clearly illustrates a minimal pericardial effusion, visible as an anechoic space surrounding the right ventricular free wall. While small, this is a supportive finding in cardiac amyloidosis, which can often present with low-volume effusions due to pericardial infiltration or impaired lymphatic drainage. In addition to these findings, longitudinal strain imaging demonstrated a polar plot with relative apical sparing, a classic feature suggestive of cardiac amyloidosis. The pattern shows preserved strain at the apex and markedly reduced strain in basal and mid-ventricular segments, consistent with an apical sparing pattern. This is an important early clue in diagnosing amyloid cardiomyopathy. To further investigate the hypertrophy and suspected infiltrative disease, a cardiac magnetic resonance imaging (CMR) study was ordered. CMR demonstrated. Panel A, native T1 mapping, showed globally elevated values consistent with diffuse interstitial expansion. Panel B, four-chamber view, displayed patchy mid-myocardial late gadolinium enhancement, LGE. Panel C, short-axis slices confirmed extensive LGE in both ventricles. Additionally, enhancement was seen in the right ventricular free wall and biatrial myocardium, a distribution pattern aligned with infiltrative pathology. CMR findings supported a diagnosis of amyloid cardiomyopathy, leading to laboratory evaluation to identify the amyloid subtype. Next, a full amyloid workup was initiated. A serum-free light chain assay showed kappa, free light chain of 38.4 mgl, normal 3.3 19.4, lambda, free light chain of 11.6 mgl, normal 5.7 26.3, resulting in a KL ratio of 3.31, normal 0.261.65. However, serum and urine immunofixation electrophoresis were negative, lowering suspicion for AL, light chain, amyloidosis. The next step was radionuclide scintigraphy using 99-MTC hydroxymethylene diphosphonate, HDP. Figure 3A and 3B on screen, HDP planar and SPECT CT. There was no myocardial uptake seen on either planar or SPECT CT imaging. This is atypical in the context of suspected ATTR. Given the strong clinical and CMR findings, repeat imaging was performed using 99-MTC pyrophosphate, PYP. Figure 3C and 3D on screen, PYP planar and SPECT CT. Once again, there was no evidence of myocardial tracer uptake on either modality. These results were again non-diagnostic. Despite negative nuclear imaging, the concern for cardiac amyloidosis remained high. The patient subsequently underwent an endomyocardial biopsy. Histologic analysis revealed Congo red-positive amyloid deposits. Mass spectrometry identified the deposits as transthyretin-derived. Further, genetic testing for transthyretin gene mutations was negative, confirming a diagnosis of wild-type transthyretin cardiac amyloidosis, ATTR-CM. The patient was initiated on tafamidis, a transthyretin tetramer stabilizer, and currently the only FDA-approved treatment for transthyretin amyloid cardiomyopathy. To the author's knowledge, this is the first reported case of biopsy-confirmed ATTR-CM with dual negative nuclear scintigraphy using both 99-MTC HDP and PYP. Interestingly, a previous case by Smiley et al. Reported hereditary ATTR-CM with negative PYP imaging. That case utilized PET-CT with 123 IAT01, an investigational radio-labeled amyloid-reactive peptide, which successfully detected myocardial uptake. Our patient, by contrast, had symptomatic heart failure and clear structural abnormalities, emphasizing that clinically significant ATTR may still escape detection on bone scintigraphy. In conclusion, this case strongly reinforces the importance of clinical judgment, multimodal imaging, and, when necessary, histopathologic confirmation. Even though nuclear scintigraphy is highly sensitive, it is not infallible. When imaging findings and clinical suspicion diverge, we must not hesitate to pursue biopsy to avoid delayed diagnosis, especially given the emerging treatment options now available. Let's continue with the next case.